It is my extreme pleasure to welcome all of you to this significant gathering in the India HPSR Fellowship Program and to mark the inaugural event of the new cohort 2024. All the very best to you, new cohort. This event brings brilliant minds and who are dedicated, this goes to all of you, in transforming the health systems. So we are very thrilled to have each one of you here. Now I would like to proceed, and we have Dr. Bonta Babu, Director in charge ICMR NIIRR NCD amongst us. And we would like to welcome him, Rajiv sir and Deva sir. Before we welcome them right here on the dais, a few words about them, about their significance, about their contribution in shaping the health policy and system research in India and contributing a lot to the global narrative as well. Dr. Bonta V. Babu sir is a distinguished implementation research scientist and the director in charge at the National Institute for Implementation Research on Non-Communicable Diseases, NCDs. He also heads the Socio-Behavioral Health System and Implementation Research Division at the ICMR in New Delhi. Holding a PhD in anthropology from Andhra University, Dr. Babu has significantly contributed to public health through his expertise in disease control program, development, qualitative research, and health education strategies. He coordinates national studies on healthcare for migrants and leads implementation research initiatives across 21 tribal districts in India to enhance healthcare access and quality under universal health coverage. Dr. Babu's extensive experience includes serving on WHO's expert panel on parasitic diseases and contributing to over 190 research papers. Can we please have a round of applause for Mr. Bonta Babu, sir? Thank you, sir. It's indeed a great honor to have you amongst us. Please, sir, come and grace the dais. Please. Now, I would like to say, and I hope you will equally like to hear about Mr. Rajiv Sadanandan, who is the Chief Executive Officer of Health System Transformation Platform. And he is my supervisor, my boss. So I'm equally thrilled to say a few words about him. Sir, it's my pleasure to introduce you. Everybody knows you better than me here. Who will deliver the opening remarks for our India HPSR Fellowship Program Cohort 2024. Sir has been a distinguished leader in healthcare policy and a former Indian bureaucrat from the Kerala cadre of the IS. With over 20 years of experience, he has been instrumental in driving health reforms in Kerala, notably as a former additional Chief Secretary of Health and Family Welfare. His innovative strategies integrated social determinants into healthcare and harnessed technology to enhance service quality. Sir served a pivotal role in managing the Nipah virus outbreak and informed Kerala's proactive COVID-19 response. He also contributed to national health programs like the Rashtriya Swastha Bima Yojana, RSBY, and has served with UNAIDS and World Health Organization. We are extremely honored, happy to have Mr. Rajiv Sadanandan with us today, and we are confident to the core that his insights will inspire everyone, including the one like me, who is a non-medical, having a non-research background in the health policy and system research journey. Please join me in welcoming Mr. Rajiv Sadanandan for his opening remarks. So please. Thank you, sir. It's my extreme pleasure to talk a few words about Devasa, Dr. N. Devadasan. He is the course director and leading faculty of Module 5, How to Write HPSR Proposal. Sir, can I also be a part of it? For the India HPSR Fellowship Program. Dr. Devadasan is a public health professional with over 35 years of experience, beginning his career by establishing a health system for the Adivasi community in Mudumalai, Nilgiris. He served as a national professional officer for communicable diseases at World Health Organization, contributing to the IDSP Integrated Disease Surveillance Program and managing outbreaks, including the Nipah virus. In 2005, he founded the Institute of Public Health in Bengaluru, focusing on health system research and training for YPs, young professionals. Since retiring as director of IPH in June 2019, he has dedicated himself to teaching MPH and PhD students while nurturing mid-level researchers in health system and policy research as the course director for the India HPSR Fellowship. Please join me in welcoming Sir Dr. N. Devadasan for an overview of the India HPSR Fellowship Program. Thank you. I would like to call now Mr. Rajiv Sanananda, CEO, HSTP, for his opening remarks. Thank you, sir.
Morning, everybody. My task is to welcome all of you to this inauguration of the fourth cohort, the program for the fourth cohort of HPSR Fellowship Program. We're fortunate to have with us Dr. Bonda Babu, who heads the HPSR unit in ICMR, and also the institute, the only institute that is dedicated to HPSR research on non-communicable diseases based out of Jodhpur. We're also happy to have Sumit, who is one of the whom you will be seeing across the period as one of the key faculty on this, and joining us because if we had asked Dr. Kumaran, who is one of the speakers here, to speak to us, it would have been, I think, 3 o'clock or 4 o'clock in the morning. So we asked him to record his speech and send to us. So he'll be joining us, through a video presentation. We also have Keshri from the executive director of the State Health Resource Center, one of the oldest and maybe the best known State Health Resource Center in India, joining us online a little later. A few words about the HPSR, which Professor Devadasan, who something which Devamitra missed in her address, I don't know whether that's at Deva's direction or not, was that he was the technical director of HSTP, who set up many of the programs that HSTP is now carrying on. This organization, the Health Systems Transformation Platform, was started functioning about 5 years ago in order to rectify a shortcoming which the sponsors of this organization felt existed in the Indian scene, which was not having an institution dedicated to health policy and health systems research. So in the activities that we do, we carry out directly HPSR the health systems research into some of the areas that are important for the health system in India. I'm afraid we haven't done too much of research into policy. But another key ingredient of what we do is recognizing that the capacity among researchers to carry out health policy and systems research in India is weak. we have this program. This is our program in which we try to build a cohort of researchers, mid-level researchers, who we hope will become the backbone of the HPSR movement in India. The extent to which it is valued by the international HPSR community is difficult to convey to you. As you go through, you'll realize that they join this program as faculty, they join this program as reviewers, they join this program as jury evaluators, and many of your application for the grant will also be evaluated by them. These are the best known people in the HPSR community, and some of the people that have, as a young student, I've looked upon as faculty. Some of the and people who are extremely eminent in their field. The moment we mention their names, the credibility of the program takes a big boost. And all these people are volunteering their time for this because they consider it to be important. The faculty who will be the core of this program are also doing this because they consider that important. Therefore, it's, as I said before, this is not an area which receives a lot of funding. It's not an area that people think is important. The reason that we were able to extend our funding to cover the future courses is because of the good work that was done by our past cohorts. The deliverables that have been made by your predecessors were so impressive that people who initially said they cannot consider extending this funding were willing to continue. Now, the extent to which we make this relevant, we make this important for the country, is by what we do. As I mentioned a little before, the other area that we have not been able to, the other area that we had promised to work on has been, it's not enough that you generate evidence. You think policymakers will just be given evidence like a pill and they'll consume it, will become all right. It doesn't work that way. It requires a lot of advocacy to explain how what you do is relevant for the policymaker. It's not as if many of the policymakers can even read a science paper. Many of you who have done your masters would have taken at least one module on how to read a paper. Now, it's not everybody who gets trained on how to read a paper, how to read it within the parameters that the author wants us to, and sometimes even beyond the parameters that the author wants us to, and imbibe it, and then make the transition from what the document is saying to what I am doing today. Trust me, it's extremely difficult. And so one of the things that we tried to do was to work with policymakers on how to use this evidence. Unfortunately, that's not an area that we have not done too well. But again, that effort is going on, and we hope to get further movement on this through another course that we are doing for physician leaders in this country. So the relevance of what you do will not only be determined by the academic quality of what you do, but also the extent to which we are able to influence the evidence generated by us onto policy, which is one of the areas in which the effectiveness of what we do is estimated. So how do we do this? One of the things is to choose people from areas that can benefit more by generating that evidence. That is normally what we call as the EAG states. As the Bible says, to those that have, more shall be given, and from those that have, even what they have will be taken away. So you will find that most of the research happens in states, or the capacity is also in states that actually need it less than those states that need it more but don't have the capacity. I'm happy to see that increasingly, in fact, in the first cohort that we took up, one of the criticism that we faced was most of the people who came through the process were such that came from the states that did not need it so much. We've tweaked that, and as you can see now, we have ensured that we get a better representation from the other states also. Second thing is, that when you work with a policymaker, the important thing, if there is one determining factor by which a policymaker can absorb, the evidence is how relevant is it to what they do. So in the first cohort, we didn't do that, but since then we've been insisting that the work should, your proposal should first be discussed with the policymakers and implementers who work in the area where you choose to work, and their concerns and their suggestions to be taken into account, so that the proposal that you generate is co-constructed. That's the best way in which we can ensure. That's one of the important ways in which we can ensure that what is produced is absorbed. The second part is that as you continue your research, to keep this engagement alive. As Professor Devadasan said, it's difficult. Even getting that time is difficult. Don't take it otherwise. I find it very difficult to get their appointments because they are such a harassed lot. You can't imagine the stress they go through. So don't take it otherwise. But you have to keep trying, and to the extent possible, to get to involve with them as you carry on with your research. And nothing can please them better if you go back to them and ask for the suggestion on when you're facing a crisis or not. The third thing is that once you've done this, again, it's difficult, but to go back and present this back to them while pointing it out, your suggestion on how it can be integrated into their work, which means that when you do your research, while you're also looking at the academic rigor, you're also looking at the applicability of what you do. So publication is important. Your research project is important, but the sheer efficacy of an HPSR project will be seen by the extent to which we are able to influence policy. So I hope that, as we mentioned before, we're also hoping to create a critical mass of institutions which has got our alumni as a faculty, to create a consortium that can possibly approach Dr. Bonda Babu and say, look, we have this much of people in so many different states, such a great faculty, and what we do can really be a multi-site study of different locations in India, because India is actually a collection of different countries, and the situation is very different from state to state. So that is our dream, that with this cohort, we'll be able to bring the institutions in which you work together to create a critical mass that can influence policy. I think that's not what I was meant to do, but I just couldn't resist the opportunity of covering these topics. As I mentioned before, this course is very, very important to us. It's very, very important to HSTP. In fact, to a large extent, it is known by HSTP. This is a signature program by which HSTP is known. And I hope I won't embarrass Professor Devadasan when I say that this has all been designed by him, his idea. And if we invited many of the faculty and the other people I mentioned wouldn't have come, because of his credibility in this area, he's been able to bring them together. And the faculty that we have had, including Sumit, whom we'll interact with later, have been the other reason why what Dr. Anand mentioned before, which is the good things that people talk about this, the fact the previous cohort talk about us. One thing that we are not adequately, because both Deva and I are very shy of publicity, is that we haven't actually adequately publicized this program. I hope you'll rectify that going forward. It's great to have all of you here. In fact, our program becomes relevant when we see your enthusiasm and the eagerness with which you will all be participating in the program going forward. In the past, we have had very somebody mentioned about whether there will be face-to-face interaction. More than that, the times when you come together virtually itself generates a kind of bonding, which again is quite, for an outsider, quite a humbling and interesting thing to watch. So I hope that this cohort will also, like your predecessors, enjoy this, have a good interaction with each other, and above all, benefit from it, and in the process, help the HPSR movement by creating the impact that this is meant to do. Once again, Thank you, Dr. Bunda Babu, for accepting our invitation, and more importantly, for agreeing to talk to our students. Thank you, Sumit, for joining us today. And my welcome to all the new cohort of 2024, and may you do very well. Thank you.
Thank you, Rajesh, sir, for your insightful and guidance, and keeping sir's message in mind that we should have the eagerness, the zeal for all the cohorts. And with that zeal, I want to march ahead with our next agenda, and also keeping sir's message that the central focus of this entire policy fellowship program should be the how to change the policy narrative. So with that, I welcome Dr. Kumanan Rasanathan. He is the ED Alliance for HPSR WHO. Dr. Kumanan Rasanathan, ED for the Alliance for HPSR at the WHO in Geneva. He has 25 years of experience, a leading public health physician dedicated to advancing global health equity and resilient health systems. Dr. Kumanan has held pivotal roles, including incident manager for WHO's COVID-19 response in Cambodia and championing the Sustainable Development Goals health agenda at UNICEF. He has significantly contributed to WHO's work on health equity, co-authoring the influential 2008 WHO World Health Report on primary health care and supporting the WHO Commission on Social Determinants of Health. His contributions extend beyond WHO, with past roles on the Board of Health Systems Global and as a Rockefeller Foundation Global Fellow. His expertise in vaccine development is underscored by his leadership in meningococcal vaccine trials in New Zealand. And before I end, I would like to share that Dr. Kumanan is not here physically present with us, but he has been extremely kind to share a message with all of us, and that we would like to hear in a few seconds. And before I welcome Dr. Kumanan, my sincere apologies to Deva sir, which Rajiv sir has pointed out that I had missed in your introductory message. So I welcome Dr. Kumanan, and can we please welcome his message with a round of applause? Thank you. Yeah.
Good morning, fellows and colleagues. My name is Kumanan Rasanathan, and I'm the Executive Director of the Alliance for Health Policy and Systems Research. It's my great honor in this festive period to address you this morning. The Alliance for Health Policy and Systems Research supports the generation and use of health policy and systems research to strengthen health systems and address social determinants of health, to contribute to significant progress in reducing health inequities and achieving major global health targets. We have been a partnership hosted at the World Health Organization for over 25 years, and we do three main functions as described in our new strategy, aiming for impact. Firstly, we support countries, mostly low and middle income countries, to generate new and impactful knowledge with national policymakers, researchers, and communities. Secondly, we work to strengthen national and regional, individual and institutional capacity to improve policy and implementation through research and learning, and to build our field and its methods. And thirdly, we advocate for how health policy and systems research can address global, national, and subnational health challenges, including advocating for global and domestic investment in the field. In our work, we work across the system, but we focus on 5 thematic areas. Firstly, the pursuit of universal health coverage through primary health care. Secondly, the digital health transformation. Thirdly, multisectoral prevention by addressing the risks and determinants of non-communicable diseases. Fourthly, building health systems resilience and realizing co-benefits in response to the climate crisis. And finally, applying a systems approach to health emergency preparedness and response, including conflict situations and outbreaks. Throughout all of our work, we prioritize and promote systems thinking, recognizing the whole of the system is more than its constituent parts. We also recognize the need to engage diverse actors and improve equity. We target our support to ensure better inclusion of and participation by women, those in low and middle income countries, and other historically underrepresented groups in health research. In addition, we organize and participate in global events. And so, for example, we're very busy now working towards the 8th Global Symposium on Health Systems Research in Nagasaki, Japan, which will occur in 2 weeks. This is the global gathering for the global health policy and systems research community, and the Alliance is a co-organizer of this meeting, as we have been since the first symposium in Montreux in 2010. And I invite you to look at our strategy and our website to learn more about the Alliance. Our field, the field of health policy and systems research, is now mature, at least 30 years old, but it still could be more visible and more utilized and more understood. Our field seeks to understand and improve how societies organize themselves in achieving collective health goals and how different actors interact in the policy and implementation processes to contribute to policy outcomes for health and health equity. By its nature, our field is interdisciplinary and transdisciplinary, a blend of economics, sociology, anthropology, political science, public health, and epidemiology, as well as many other disciplines that together draw a comprehensive picture of how health is created and destroyed, and how health systems respond and adapt to health policies, and how these policies can shape and be shaped by health systems and the broader determinants of health. Health policy and systems research, unlike other forms of health research, is very interested in bridging the no-do gap on the how and on the why. We're not content just to describe health problems. Our central mission is to consider how can the policies and interventions that we have evidence of their effectiveness, how can they be delivered? How can they be delivered at scale? Why aren't they delivered? Why aren't they implemented? Why is their delivery and implementation so inequitable? And how can we fix this? We seek to generate actionable insights that can inform policy and practice and ensure that everyone benefits from the interventions that are available and that we know work. We are sure that health policy and systems research can generate impact. And the reason we are sure is there are so many examples from around the world where this has occurred. For example, in Ghana, health policy and systems research has played a crucial role in enhancing maternal and child health service delivery through understanding the barriers to effective service delivery and identifying strategies to improve access and quality of care. And we see this has led in particular to the implementation of the community-based health planning and services program, bringing healthcare closer to people to improve maternal and child health outcomes. In India, health policy and systems research has shaped the response to public health emergencies like the COVID-19 pandemic and the Nipah virus outbreak. It's helped to improve social health insurance schemes. It's working on improving digital health and mobilizing digital health to improve service delivery and improve equity. In Kenya, health policy and systems research has improved the performance of the health workforce, looking at factors such as motivation, retention, working conditions, training opportunities, and support systems. And these insights from our field have led to the development of targeted interventions that have enhanced health worker performance and improved service delivery. We at the Alliance have worked along with Gavi and UNICEF and other partners for over a decade in many countries to support implementation research to improve immunization service delivery. And we have examples such as in Nigeria, where this work has led to improvements in EPI coverage. So by addressing the why and the how, health policy and systems research provides valuable insights that improve the implementation and effectiveness of health interventions to improve the health of people. So congratulations on being part of this exciting field that we so believe in and that we work towards as a global community. Congratulations on your selection to one of the few health policy and systems research fellowship programs for mid-career researchers. At this stage of your career, you have the option to engage with policymakers at the district and state level to identify research topics that could contribute to improving the health systems in your area and help them assimilate the evidence generated by research. With the skills you acquire in this fellowship, you have the option to move beyond the academic silos and carry out research embracing multidisciplinarity and complexity, leveraging the experience of practitioners and communities. This will enable you to emerge as a leading figure in this field, as so many of your countrymen and women have done, and give you the satisfaction of seeing your research improve health systems in your area of work and the health of people in your communities. Ours is a practical and applied field. Papers, whilst can be important, are only a means and never an end. So once again, congratulations to all of you for being part of this course. I look forward to seeing your inputs over the next couple of years to strengthen the Indian health system by generating actionable evidence that can help policymakers and implementers make the necessary changes to achieve universal health coverage and improve the health of Indian people so that all in India, almost a quarter of the world's people, can achieve and enjoy health and well-being for all at all ages. The goal in the Sustainable Development Goals that all countries, including India, adopted in 2015 to achieve by 2030, which is now quite close. So thank you. And again, let me wish you all the best in your endeavors.
Thank you, Dr. Kumanan. So what Sir has reinforced and reiterated is that the why and how. And we all know that it's all about the last mile delivery when it comes to healthcare. So apart from the last mile delivery, it's also, like Sir said, I really want to quote him, is like bringing healthcare closer to people. So moving on with the agenda, we have now amongst us Dr. Bonta Babu, who is the Director in Charge, ICMR, NIIR, NCD. Dr. Bonta B. Babu is a distinguished implementation research scientist and the Director in Charge of the National Institute for Implementation Research on Non-Communicable Diseases. He also heads the Socio-Behavioral Health Systems and Implementation Research Division at the ICMR in New Delhi. Holding a PhD in anthropology from Andhra University, Dr. Babu has significantly contributed to public health through his expertise in disease control program development, qualitative research, and health education strategies. He coordinates national studies on healthcare for migrants and leads implementation research initiatives across 21 tribal districts in India to enhance healthcare access and quality under universal health coverage. Dr. Babu's extensive experience includes serving on WHO's expert panel on parasitic diseases and contributing to over 190 research papers. Dr. Bonta B. Babu will be talking about the importance of implementation research in the Indian context and introduction to NIIR NCD Jodhpur. Can we please have a round of applause in welcoming Sir?
Thank you. Thank you so much for your kind words. Good morning, everyone. I'm very deeply honored to be here as the guest for the inauguration of the 4th cohort of the India Health Policy and Systems Research, which is anchored by HSTP. And I also thank Professor Rajiv and Professor Devadasan for inviting me here. First, I would like to acknowledge and congratulate HSTP for successfully completing 3 cohorts of this unique program as a mission to build the future of the health policy and systems research in the country. Because I have gone through the names of some of the previous fellows of these three cohorts who are really contributing to the nation in various issues, right from the implementation research to policy making. And now I welcome the fellows of fourth cohort. You are embarking into the new journey of health policy and systems research. I welcome you. You are stepping into the field which is very much essential for the country, where really the systems research is to be taken on priority, because we know that from years together, most of the policies are not evidence-based, and now the scenario has been changed, and we are making the policies in a very appropriate way based on the evidences. And you are going to the part of these exercises. Currently, I was asked to talk about the importance of implementation research in Indian context. Of course, I would like to introduce NIR and CD as well as ICMR. But we are aware that this implementation research is, of course, the part of HPSR. Implementation research give a kind of direction to the policy, how it should be or how it should be evolved, and simultaneously implementation will act as some kind of loop feedback. Okay, I can say otherwise that when health policies guide the implementation, how to implement in the field to reach the communities, and at the same time, the implementation research will tell us that what are the problems in the policy and what modifications are required. So that way we have very close collaboration between the health HPSR and implementation research. But coming to the ICMR, because I have a small presentation on what are the various priority programs of ICMR, which are more relevant to HPSR or implementation research, and that I will take at the end of my speech. First, I would like to speak very little about implementation research, because I have seen the profile of the fellows, because most of the people are in the middle, or none of them, I believe, that at the beginning of the career, but they are well acquainted with implementation research and HPSR. So I believe that they know very well that implementation research is a discipline, very critical discipline, that translates our proven health interventions and health, I can say that innovations into practice. Okay, it's about make sure that the great ideas which we developed through our academic research or maybe the practice should not be limited to the papers or maybe in the form of research papers. Rather, it should take effectively to execute into the system to benefit the people. This is ultimately the overall philosophy of implementation research. And I can say that some of the great examples in which India, in our country also, we are implementing now, that ICMR has initiated a study on optimizing the services of health and wellness centers. We started this study in 11 states. I think Dr. Raju sir also might be aware of this one. We started almost not less than a year back, because we are aware that what transformation happened in primary healthcare in the country after Ayushman Bharat's introduction of Ayushman Bharat. Earlier, we used to limit to only maternal and child health services, or sometimes maybe to some kind of episodic illnesses. Now we expanded these services across all the health problems, including geriatric care, of course, NCDs, geriatric care, trauma, others also like ENT, ophthalmic, all these issues we are covering under primary health care. So it's a great transformation, because we are aware that the need of strengthening primary health care. Okay, ultimately to reduce the burden at tertiary and even at family level. So with the time, the government of India has initiated the Ayushman Bharat Health and Wellness Centers. And of course, we are aware that the coverage is still very, very low. In fact, in many states, the transformation of health sub-centers, because we thought to convert the health sub-centers as health and wellness centers with the primary objective to deliver all these services, because we mentioning the 12 CPSC services, comprehensive primary healthcare services, right? This is a priority for the government. We are working on that one, and to some extent, even within a less than a year, we could influence the governments in those districts to transform the current health sub-centers to health and wellness centers and appoint community health officers. And they are able to deliver some of these services. They are going beyond maternal and child health services. This is one of the examples. And similarly, earlier we had studies on migrants' healthcare, which ICMR took it as a priority area. It is almost 5-6 years back, where the newcomers to the cities are completely neglected by the system. Because of both the systems problems as well as the migrants' issues, they're unable to receive primary healthcare in the cities. Various reasons, system-related reasons, as I said, that because the newer areas where they settled are not covered by any of the health facility, or because they don't want to, the government don't want to make them recognize, they don't want to recognize them, because once they recognize for any of the services, it leads to other complications that they demand for other services. So government intentionally, many times intentionally excluded. So through implementation research, we could make some changes in the system that in some of the cities, even in Delhi also, we made them understand the importance of newcomers. In fact, we advocated that the newcomers are very important for urban development, for infrastructural development. So we have to provide the primary health care. And we created a policy in some of the South Delhi Municipal Corporation that, yes, there should be a mechanism to inclusiveness for including the newer habitations. Similarly, in other cities also, made some changes in their policies. Even may not be at state level policies, at least municipal corporation level policies, we could make some changes to have an inclusive policy for urban migrants. So similar kind of examples we have. Currently, I will explain later on, I think we have around 15 projects which are named as National Health Research Priority Programs of ICMR. So this definitely, because I would like to emphasize that implementation research is the science or the practice where the known innovations, known interventions, or proven innovations or proven interventions can be made useful for the public, for the people, right? Ultimately, it is very relevant now globally because the health systems are everywhere, are becoming more matured, and they're able to, what you call, deliver. But at the same time, some kind of implementation research is required to effective delivery of these services through by using these policies or using the system. So I would like to mention that we are not just the fellows of HPSR or the experts of public health. We are the future leaders for this endeavor. Definitely, you will help shape the health systems, particularly when there is need, particularly when there is a crisis, when there is emergencies. Your expertise is very much needed. The skills which you develop through this fellowship will definitely enable you to drive towards the real change in health system or benefiting the people. Okay, and also remember that your efforts have very ripple effect. The health outcomes, even if you can work on a single issue like a maternal care or reducing neonatal mortality, or maybe increasing treatment for tuberculosis or identifying newer cases of tuberculosis. Even a single will give a lot of what you call impact in the population. So I would like to welcome you again to this very important what you call profession of HPSR. And now I emphasize, because I mentioned earlier that you are all at mid-level and we are well known in the subject. Some of the key expertises or skills for success as implementation research scientists. One is critical thinking. It's very important, because I think after reading the implementation research, we will understand that it is not like any other subject, just it is very, having a single textbook. Okay, we can understand by reading it. It's not like that. Okay, critical thinking is very much important. You have to embrace critical thinking during your practice of implementation research, because the public health challenges are very complex. The policies are very complex. The dynamics across the system and policies are very, very complex. You have to understand those complex dynamics, and we have to embrace the thinking of how it is happening, why it is happening. Okay, that is very, very important. You have to think strategically many times and have to have your own innovations while implementing the strategies, whatever you are thinking. The second thing is adaptability. Adaptability is another important, because in health systems research as well as in implementation research, we have so many frameworks. Okay, but you have to remember that these frameworks are some kind of guidances only. Okay, if you take CFIR, Consolidated Framework for Implementation Research, or Logic Model, or any other framework, they are able to guide you. They cannot tell, these framework can't tell that you do like this, like this, like this, because they're very, in almost all situations, they are very contextual. So you should be very adept. You have to see you have to examine, you have to critically think the situation, you have to be adapt to in the real world. Okay, don't think that always things go as you are planning. Okay, the way you plan today may not be applicable tomorrow. So be adaptive. Don't stick to the frameworks or textbooks, because these are very dynamic and ever changing. We have to realize these changes. And also, I think you know that the culture or the community dynamics of the people, they're keep on changing. They're very dynamic, so that we should be very adaptive to implement these policies. The third one is lifelong learning. It is very important, because we should have the past, current, and future knowledge on all these. Okay, because you have to have the knowledge on how the health policies have evolved. You should have the knowledge on how in 1948, how the Board Committee said that at the time, the priority is the personal hygiene and some infectious diseases. Now, a lot of changes happened. Now we are focusing on non-communicable diseases. This kind of Board Committee in 1946 to National Health Policy of 2017, okay, to across how it is evolving. And we have to have the lifeline. We have to have the culture of learning. Okay, in implementation research, this is also very important. These key skills are very important to be an implementation research practitioner. And lastly, I be realistic, because many times very frustrating. I think like Rajiv sir also told that working in implementation research leads to many times some kind of frustration as well as depression also, because we are facing all this now. Because we think that in Delhi, by sitting here, that these are all very important and have to change. So people are suffering, we are the people to change. But when you go to the field, when you go to even in the district headquarters, if you district medical office, they say that everything is perfect, you need not worry much. So we have to be very optimistic and also realistic that what is going across the system. So you should be very honest. And again, I'm telling that it is not so easy to make the changes which you are expecting or which you are desiring. So many barriers, right from the system as well as from the communities. Even many times people also don't want, because we have very good experiences wherever, because I worked on lymphatic filariasis. It's because WHO massively started global eradication program. Right, at the time when we go to municipal corporations as well as even local panchayats, including communities, their problems are totally different. Okay, because it's our priority. Right, people have their own priorities. When you go for, sir, we here we are not getting water, you please do something for getting water. Right? See, these are all the challenges, because we have to be, because a lot of logistic issues, a lot of cultural issues, a lot of resources related issues. Okay, we have to realize with all this, as I told, that don't be depressed or frustrated, be optimistic, keep on working. And another most important thing is the importance of research. Always don't forget about that one. Many times the data will help. Recently, I went to one ITDA, it's called Integrated Tribal Development Agency, which is headed by a senior IAS officer. It's called Project Officer, PO ITDA. When we went there about a universal health coverage project, he told me that everything is perfect. What research is required here in our tribal area? Because see, something like it's very closed, small kingdom. I'm managing everything perfect, and health system is perfect, and we are managing very well. Sir, then I said that, sir, it is only the fully immunization coverage in your area is only 80%. And about 10 to 12% of the people are partially immunized. And definitely 8% of the children have not received a single vaccine in the last 2 years. No. Who said this? Any ANM told you? Tell me that who is that ANM? No, it's not told by any ANM. It is the data we collected. Data, how many households we covered? I said it's around 4,000 plus households we covered. And it's very randomly. No, it's 4,000 for entire tribal area is not enough. It's not correct. Your estimations are not correct. Then I have shown that which formula you use, WHO manual, everything I have shown that to some extent we could able to convince that, okay, some people are not covered. See, that way you have to always depend on the evidences. Many times in implementation, particularly, people, particularly the bureaucrats, apologies to Dr. Rajiv sir, don't like to accept, because it's a culture in our bureaucracy, maybe. That's the reason we are having the what you call underestimations of many illnesses also. Underestimation of malaria, underestimation of tuberculosis. We don't like to accept my weaknesses. It's a maybe human tendency. So same tendency reflect in the health system also. So many bureaucrats don't like that it is not happening. They always believe or pretend to believe that things are going very well. So no implementation research is required here. So we are able to manage. So your duty is to have data sufficiently to prove that it is required. Okay, don't use the data for criticizing the government or criticizing the system. You highlight the data for the need of implementation research. You say that some improvements are required. Sir, you are doing very well. 80%, achieving 80% is not easy thing in a tribal area. You have to appreciate that one. But this 20%, where we need something, you have to do something. That you have to highlight, you have to use the data for that one. So one is be optimistic or be realistic. Second is depend on data. And don't depend on, maybe Dr. Prashant may not be happy for my words, that don't depend too much on the frameworks. Okay. Very adaptability is very important in the field. You have to be adaptive to the situations. You have to adapt to the dynamics of the communities, adapt to the systems dynamics. Then you can be a very good implementation researchers. Okay, with this I show the important projects which we are undertaking at ICMR level. After that, I will conclude. Yeah. Right. This is actually a very important activity the new Director General initiated, the NHRP projects, National Health Priority Research Projects, because before conceptualizing these projects, we met the Health Secretary, Government of India's Health Secretary, along with all his joint secretaries who are looking after various divisions of the ministry. And we identified various reasons where really government wants some kind of research, where in fact not research, some kind of improvement. And they gave a big list of issues where government is facing some problems during implementation. And based on those, we identified for this year around 15, I think we are showing 15 projects to be implemented. And these 15 projects are all are multi-centric projects with the close collaboration with the state governments. The selection is such a way that because some of our colleagues, Dr. Prashant and others also involved in that, that we gave a nationwide advertisement for EOIs, expression of interest. The teams which have some experience in HPSR as well as implementation research, we identified as a team, and the compulsion in that team constitution is the involvement of the state or district health system. Okay, through competitive method, by identifying the geographical importance, we identified it from the 8 to 15 teams under each project. And the Director General himself spoke with all the health secretaries of the states as well as district officials to be part of this project. It should not be, because he wants that it should not run as an academic project, rather than it should be the project of the state government. So most important thing is that, of course, we are not going to change any policies at either a district level or at a state level, but the implementation, and we are trying to understand what are the implementation problems. Okay, if really there are the problems related to the policy, of course, we can discuss, because the evidence we are getting is nationwide evidence, so that we can influence the national government also, because it is the issues which are raised by or which are included in these projects are obtained through the national government, so that we can influence this national government also. Of course, very seriously, Dr. Vinod Pal, who is the member of Niti Aayog, also involved in identifying the areas, as well as in many of our meetings he involved, even at the level of protocol development. Right, next please. Okay, I can use this one. Yes. Right, this is just I am mentioning because I am not fully involved in all the projects. I know about some of the projects in detail, but at least I can tell, you can see the title and you can understand. Also, I would like to mention that this year also we are going to give again the similar kind of advertisements on remaining issues, so that I welcome you to part of these projects, and please apply as teams and seriously involving the state governments, because many of the researchers, because as while introducing me, I was informed that you were informed that I headed the division of health systems and implementation research, because I have seen many projects, even health policy and systems research projects, as well as implementation research projects. In many projects, the participation of state government is very nominal. Okay, for the namesake, they mentioned that district medical officer's name or somebody's name, but actual participation is very, very less. So it should not be like that. Okay, please make teams and please apply, respond to our calls, so that we'll be very happy that people like you should be the part of this exercise. But this is about strengthening program implementation monitoring to achieve single-digit neonatal mortality. This is targeted for neonatal mortality. It's a multi-centric study. I'm not going to details so that you can understand the titles at least. So what kind of projects are covered under this scheme? Right, it is going across 8 to 10 districts of the country. Because another important thing is here, the implementation unit is the district. That means that entire district. Because if any study taken in very small areas like 1 or 2 PSAs, definitely we will try to demonstrate that it is a success. Okay, our intention is to see that in relatively at larger geographical area, it should be successful. So in all projects, we made the district as the implementation unit. But another project which is important, in fact, this project is managed by me as the national coordinator. This is for what I said, that Ayushman Bharat Health and Wellness Centers. Okay, and now we are mentioning as Ayushman Bharat Mandirs. Here, our objective is to develop or co-develop. We are mentioning that co-develop because in implementation research language, co-develop is very important because it's not, we are not developing, we are developing along with the health system or the health managers, like this, maybe from state to district level. Okay, co-develop a context-specific implementation delivery model for Ayushman Bharat Health and Wellness Centers that can deliver 12 quality comprehensive primary healthcare services with high coverage equitably. This is the idea, because I told already that it's the program itself is a new, because the system is habituated for only a few services like maternal, child, and other similar kind of services. So we are expanding these services to 12 services, right, from maternal care to the geriatric care, including so many. Right, this here we made two sets of districts. In one set of district, we are using the technology, leveraging technology is one of the, as well as the if you see the second part, there's a green, okay, IR with interdepartmental convergence and leveraging technology, because we adopted it's a strategy to improve the services, right? Otherwise, in the first group, just we are taking the governance and management issues are the primary strategies, and we are continuing this in the first set. In second set, the technology, particularly digital technology, is very important, and we are trying to leverage intensively in these districts. Right, this is some framework that how implementation should be done by having a formative research and implementing zero model. Then it's I'm not going to explain all this. The most important thing is, which we are advocating with the state governments, is that we are not telling the state governments to make more investments for these projects, or we are not saying that more staff to be deployed there to make this happen. Our advocacy is such a way that only with small changes in the competency level, by providing trainings and orientations, managerial skills, motivation, that kind of inputs are to be there, and we are highlighting that no additional charges. Okay, human resources, same supplies, but only thing is we need to have some changes in the governance. That is more important. Otherwise, whenever you say that we are implementing a new strategy and we need this many crores, means state government people initially first say that it's not possible. And also, it's not a great innovation also. Spending money and achieving is not a great. Without spending money, additional money, if you make some changes in the orientation or maybe governance, okay, definitely many state governments will welcome for that kind of changes. Right? Funding, no change. Equipment, no change. No additional human resources. Only in between technology, leveraging technology, linking with various departments, governance issues, training issues, they are to be strengthened. Right? The another study, which is on patient-centric integrated model for emergency care. This is also very much neglected and also limited to only tertiary care. So we identified some of the emergencies, right from STEMI to neonatal emergencies. In between, you have trauma, burns, snake bite, respiratory illnesses. Okay, this is one of the projects. This is also going across the country. The other one is integration of screening and management of mental health and substance use, along with other NCDs. Okay, this is of course the Ayushman Bharat has taken NCD's component very seriously. And in fact, in many health and wellness centers, this is going on. This component is after and the initial stages of health and wellness centers, okay, this part has been taken. Now it's going on. Now we are going to strengthen this part. The other one is on suicide risk reduction, because in India, because data is showing that the burden of suicides is increasing. So particularly among adolescents, school going and college going students, so that this is also one of the national health research priority, and we are conducting this study with a kind of interventions. Most of these interventions will be or can be implemented at primary health care right from the health and wellness centers. These are the centers where we are implementing this study. And this is on dental or oral health. Okay, because the burden, because the data shows that, because some of you, we are here also, we have some oral health specialists, that almost 80%, people are saying that 80% of the particularly children and adolescents are having various kinds of dental problems, including caries. Okay, so to address that one, this is one of the National Health Research Priority Project. This is very important study. The reduced prevalence of anemia among vulnerable populations in some districts. Anemia is one of the priority public health problems in the country, and through this implementation research, we are addressing this one. Okay, test, treat, and track individuals. These are all part of, because whichever the IR project you see, implementation research project, you see that the interventions, the policies or system related mechanisms are not new. All exist in the system. Only thing is we have to make them to happen. Okay, that is the what you call principle of implementation research. This is reducing stillbirths, because stillbirth rate is very high in the country, and this is addressing through this project. This is also a multicentric in 6. I remember that it's a 6 states, 6 districts. Strengthening ambulatory care for NCDs. This is another area. Targeting diabetes, hypertension, COPD, particularly chronic respiratory illnesses and coronary artery disease. Okay, with the focus on these 4 diseases. Okay, we have taken this study. This another study, again, it's focusing on hypertension, diabetes, SEPS India multicentric study. Okay, mostly it is at the community level, that is health and wellness center level study, where we are strengthening the communities as well as the primary health care. Similar to that one, it is using digital technologies for improving the continuum of care or promoting continuum of care. Okay, continuum of care is very important in NCDs, particularly diabetes and hypertension. This is one of those studies, how digital technologies can be leveraged for achieving that one. This is also an emergency care, for providing high quality integrated emergency care among red triage patients at all levels. Because we don't have, because now if you see the set of comprehensive primary health services, trauma care is one of them. Okay, at primary care level itself, some kind of trauma care should be provided, and there should be some kind of referral system from the primary care itself. That means from health and wellness center level itself, so that to strengthen that trauma or emergency services, this study will be useful. Yeah, this is on cancers, oral, breast and cervical cancer. This facilitates at the primary healthcare level that how to initiate the screening at community level, early diagnosis and initiation of the treatment. These are the objectives of this project. Okay, these are all different kinds of national health priorities projects which ICMR is initiated, and we are going to initiate some more project this year also, because we started all this in the early 2024. We started processing or initiated the processing in late 2023 and started in 2024. Hopefully this year in the 2025 beginning, we'll start giving the advertisements for this kind of projects. And I request all of you to be a part of these projects, because most of you are because the condition of ICMR projects is one should have some permanent affiliation, either to medical college or maybe to NGO or private universities, private medical colleges. All are eligible, but one should have a permanent affiliation, so that I have seen the profile of fellows that all are having some permanent affiliation, so that I welcome you all to part of this one. Okay, now I close my speech by welcoming, because regarding NIR and CD is a part of ICMR. It's one of the 27 institutes of ICMR, and we are part of most of these studies. In fact, we mentioned NCD in our title, but we are working beyond NCD, even maternal child health and communicable diseases also. We are working on malaria as well as tuberculosis and non-classic NCD like sickle cell disease. We are working on all those diseases, and we are trying very sincerely to drop the word NCDs. Okay, we want to make it National Institute of Implementation Research. And I also welcome you to visit NIR and CD, Jodhpur. We are located in Jodhpur. And if you want to experience in Rajasthan or to see the health system in Rajasthan, okay, we have plenty of projects. You can accompany our scientists and interns and fellows. Okay, you can interact with them. They also learn from you. And also, you also can learn by visiting our field and the way we are implementing the projects. Okay, I welcome you all to Jodhpur. Okay, because some of you might have having my contact number and email, so that you can contact me, and we have very good facilities there, including the first stay guest house we have, so that you can stay there and you can see the activities which we are conducting there. Okay, with this I stop here. I wish all the best for this fellowship and career. Really, you need, the world need you, not only India, globally, your efforts and your expertise is needed. Okay, definitely I am confident you will rise to the challenge, and you will meet the expectation of the HSTP also. Thank you all. Thank you again for inviting me.
Thank you, Dr. Mota Babu. And now I feel tempted that whether I should go back again to research with what I have started my career, because thank you, sir, for such a beautiful storytelling session and making implementation research sound and hear so interesting. And before I move ahead with the agenda, here's a small update. Dr. Prashant N. Srinivas has joined us. And do I hear you clapping and welcoming him, Cohort? So he's the leading faculty for Module 1 on Health Systems in the India HPSR Fellowship Program. Now I get back to my agenda. Our next session is with Dr. Vikas R. Kesri, sir. He will be talking about the HPSR in India. Sir, it's an extreme pleasure for all of us to have you with us, who is serving as the ED of the State Health Resource Center in Chhattisgarh, joining us virtually today for a session, as I've already mentioned, Health Policy and System Research in India. An accomplished public health leader, Dr. Kesri holds a PhD in public health from the University of New South Wales, Sydney, as well as an MBBS and MD in community medicine from MGIMS, Wardha. His expertise is further enhanced by his training as a Keystone HPSR Fellow and Health Policy Fellow from ITM in Antwerp, Belgium. With over a decade of experience, Sir specializes in health policy, system enhancement, human resources for health, maternal health, and burn injury. His significant roles at organizations such as the George Institute for Global Health India and the Center for Health Policy in Bihar have greatly contributed to health improvements at community and policy levels. Dr. Kestri's impactful research has influenced both academic and policy domains with publications in esteemed journals and active participation in health policy dialogues. Today, we really look forward to his session, to have him even though virtually with us, and share his insight with all of us. Thank you, sir.
Thank you. Thanks for this wonderful word of introduction, and good morning. And I welcome all the fellows and faculty member who have joined today for this inaugural session. And it was very nice to hear Dr. Bonta Babu's detailed plan about this national health priority research, which is very closely related to health policy and systems research agenda. So, yeah, again, to begin with, I would like to thank Mr. Rajiv Sadanandan sir and Dr. Deva for inviting me for this inaugural session, and all the fellows. To you, I will say that this is a bit of deja vu moment for me, because more than 15 years ago, I was sitting as a fellow in probably one of the first India Health Policy System Research Fellow called Keystone Fellowship, which was jointly organized by the Public Health Foundation of India and Alliance for Health Policy System Research, with many of faculty members like Dr. Deva and Prasant and other. They were part of the faculty at that time also. So what I think before I move on to my presentation and detailed discussion, I would like to share my personal experience, and that is also part of the presentation later on. That that particular 15 days training in 2015 February was, I think, one of the turning and defining moment of my career. And I'll share in detail about that. So what I wanted to emphasize here for fellows that this all as Dr. Bontaba was emphasizing, many of you are mid-career researcher. You have started on your research career. You are some way advancing into your public health career, but probably this particular fellowship and this training will give you very critical and important hat, which will help you in deal with day-to-day research challenges as well as problem-solving challenges in health systems. So I welcome you, and I feel that you have those who are selected for this course are fortunate to get this training and this kind of opportunity to expand their horizon on health policy system research. So I think the topic I was allotted, and when I had a discussion, it was more about my personal journey, how I metamorphosed into a HPSR thing, and how that helped me in professionally growing and helping solve some of the health problems. So I'd like to share a presentation, a brief one. Okay, here you go. Can you see my presentation? Yeah. Oh. Can you all see my presentations? Can someone raise hand and I can recognize that you can? Yeah. Thank you, sir, and thank you, Dr. Deva. So yeah, so I'll be dealing with health policy and system research aspect in India, combining my presentation in mix of two things: how the evolution of health HPSR and health system strengthening in India happened, and how my personal experience of different trainings and lived experience and also experience while working with health system saved my HPSR thinking, and how these kind of short-term training like Keystone or like health policy fellowship in Antwerp and shape career of a mid-career researcher who has largely been trained into epidemiological method, but dealing with health systems problem. And I'll conclude why everyone, as I believe, and I think most of us in this room, especially the faculty member and HSTP leaders, they strongly believe that HPSR is an important and probably one of the most important aspect as a researcher or as a public health advocate we should have. So I think before I move forward, I think as we realize that there has been changing global trend in thinking about health system. And I think the most important movement on that was 1978 Alma-Ata Declaration, which introduced the concept of PSC and definition of PSC, the key function of PSC. So after that, the primary healthcare took the center stage, but not immediately, because it was also believed that PSC is very broad and very comprehensive and probably very difficult to achieve. And based on advocacy by different actors, the selective PSC, primary healthcare concept came, and then UNICEF introduced this GOBI FFF, which is like growth monitoring or ORS, breastfeeding, immunization, and controlling female fertility and education and etc. So means emphasizing on selective primary healthcare. And then in 1990s, with the World Bank's influence and this structural adjustment program, and the 1992 or four, I think the kind landmark report on investing in a health system, with introduction of Delhi and everything, there were more kind of effort shifted towards making health system more efficient, cost effective. And then in 90s and after 1980s and 1990, am I good? Am I audible and good? I am getting a message from Sayed that something.
You are audible. Is it okay if we can share the screen?
Yeah, that's fine. Please go ahead. Should I stop sharing then? Yeah, you can share now.
Please continue.
Sayed, I cannot see the slides.
Give us a minute, sir. We are working on it. Thank you for your patience, sir.
Okay, yeah, I can see it now. Yep. Yeah. So health system, and then in 1990s, 2000, again, the focus reshifted on disease control program and prioritizing maternal and child health care, especially after the emergence of HIV/AIDS. And then in 2000s, and most importantly, later in 2010s, this last decade, the concept of universal health coverage is actually predominating over all other kind of domain of thinking of health systems, or like healthcare. And then more recently about primary healthcare too. And so I did an exercise and tried to, can you go to next slide, please? Yeah. Try to see evolution of India's health system in same context. Yeah. So India had a British health system. We have a colonial past, and during British colonial era, I think the health system was very select. Can we go back, please? Is it in slide save mode? I think it's moving up automatically. No, go back to the previous slide. Okay. So yeah, so I think India's public health system in British era was very selective health system for elite, probably with the invention of district hospital. But after the independence, with Boer committee recommendation, lots of emphasis went on to build primary healthcare systems. And but owing to global debate, MCH and predominated in 1970s and 1990. So I personally believe that 2005, the introduction of National Rural Health Mission was a very critical point in India's health system evolution, when emphasis shifted back onto health system strengthening. Although the major focus of NRHM remained the reproductive and child health program, but there were lots of discussion around strengthening overall health system to achieve those goals of reproductive and child health system. And especially after 2015 in India, there is good discussion and deliberation and focus on providing universal health coverage, particularly by two means. One is by strategically purchasing, care from private sector and also from public sector, and then strengthening comprehensive primary healthcare through expanding the focus of existing primary healthcare system through the Health and Wellness Center or Ayushman Arog Mandir thing. I think with this background, can we go to next slide? So this was kind of, I tried to explain that how I read and understood and probably experienced evolution of health systems thinking globally, and then in India where I experienced some of those things. So I'll now shift on to my career journey and how I metamorphosized into HPSR and probably becoming, or probably today consider myself as one of the key kind of promoter of HPSR in India. So I was born in a small town in Bihar, and my mother and some of my relatives, they worked in health systems, and I have been experiencing the challenges of health system and its complexities in childhood. There were lots of discussion around happening in home about those critical challenges. And when I relate back to those critical discussion now, I feel that many of them were existed because there was complete lack of systems thinking. There was lots of emphasis on a kind of vertical thinking, solving problem, or directly, very in a straightforward manner. Yeah. Then in my public health training in MGIMS, where during MBBS, the training was largely focused on community-based medical education. So we got exposed to the community and their problems. But during my MD in community medicine, I got lots of training on epidemiological research, but my MD dissertation was focusing on a health system problem, which I personally believe that is one of the most complicated health system problem is solved. That is making emergency obstetric care equitably distributed and functional. So I did, and I did that in a quite nationally with involving 9 states. And I used to visit visit their first referral units and district hospital, trying to understand the operational barriers in operationalizing the emergency obstetric care, especially focusing on training of medical doctors, like MBBS doctor being trained in obstetric care for 4 months, and so in anesthesia care for 6 months, and how despite their training, there was hardly any utilization of trained doctors in operationalizing FRU. And at that time, I used to realize that, oh, this is a vicious cycle. Operationalizing an FRU is not only by strengthening your human resource, you have to strengthen 4 or 5 key elements, and those elements has to function together in order to make one FRU functional. And then, can we go to next slide, please? Yeah. And then, so this is the paper which I wrote, much later about operational barrier. And then I ventured into, after my MD, into, mostly health system strengthening space, like working in teams mandated with providing technical support to large state governments in India. And there I realized that again, there has been lots of focus lately on data, but how to analyze that data with a system thinking approach, with a multiple kind of, thinking in a cycle rather than thinking straightforward, was missing. And there I got this opportunity of, participating in Keystone Fellowship. And I think my lived experience and my early career education and research experience, I was thinking about all these issues which got a bigger framework and lens during HPSR training later on, but I didn't have a clear, I will say, articulation of those issues. And what HPSR where HPSR training with starting with Keystone and health policy and later on PhD helped me in identifying those articulation, those framework and those methods by which I can articulate those problems better, and then kind of deal with health system stakeholders or like policymakers to make them come on board that this is required. You have to kind of work on the entire system to improve one part of the system. So, and then I worked in Bihar for quite 6-7 years, and I think in Bihar we had this Center for Health Policy functioning in 2017, and then we had a few rounds of kind of meetings, deliberation, and workshops where we discussed about those HPSR issues. And then, finally, in my PhD, which started with a systems topic, but it was more focused on burn injury. I changed that into making a larger inquiry into health policy and system response to burn injury. Again, a very complex issue and a very challenging issue with multiple heads, similar to maternal health or emergency obstetric care, which require strengthening many part of the health system to function for me to make it more responsive and comprehensive. So yeah, I think that is how my career evolved and how one training with HPSR fellowship on Keystone I still rate as a changing point of that entire thinking process. Moving on to next, please. Now, to talk about the current thing in SHRC. Now, for last 1 year, I'm heading the State Health Resource Center at Chhattisgarh, which has been, again, this is a pioneer institute, as Rajiv sir highlighted in inaugural speech, and it not only kind of helped country develop ASHA program, it also kind of was critical in developing many of the initiative under the National Health Mission, thanks to visionary leaders, my predecessor earlier who worked on those issues. Even currently, SHRC is very closely engaged with the health department in Chhattisgarh. And we not only just work on health system strengthening or supporting the community health worker program, but we are also, and thanks to my predecessor again for setting this up, very keenly engaged in producing research evidence. And I must say that those research are being generated at a very low resource, mostly funded through the different government programs, or just funds coming out of a small saving from an implementation program. So SHRC had a vibrant, I think, research output and research kind environment. And what I did tried to do in 1 year, I will not claim that now, but did in last year is that trying to introduce HPSR thinking into that. And some of our recent publication is testimony to that. We tried to understand how community perceive, development of health and wellness center and how they see it, and like how is the performance of health and wellness center is faring, on different parameters, and how governments like publicly financed health systems is performing in Chhattisgarh and neighboring state. So we used to have regular session discussing about these issues. Some of the pictures are here showing. We used to advocate this very strongly. So another, I think, critical success of SHRC in recent time has been that we were very closely engaged with senior bureaucrats in government, trying to sit with them, sharing our presentation and our work, where they used to take this opportunity to learn some of these issues from a different, like, research lens. The previous additional chief secretary health in Chhattisgarh had a kind of dedicated 1 hour every Friday sitting with me and SHRC team discussing our recent data or research output or any insight from field. So that is and one of the reason I chose to come back to SHRC after a stint in Sydney in Australia with George Institute in UNSW was getting this opportunity to work closely, making impact closely while working with the government, while working with the policymakers. Can we get to next slide, please? Yeah. So with this background, my personal journey and my evolving understanding about health systems, I think if I have to define how health policy and system research kind of explain how health HPSR evolved in India, I think in India, as everyone, most of the faculty members probably and some of fellows must be knowing that health research is mostly, biomedical focused and with dominance of epidemiological thinking and methods. Method will remain. I think most of the method in HPSR, what we use can also be classified as an epidemiological method, and that is pure. But so we'll not go into that debate. probably the designing of research question, which probably will be explained to you later by the faculty member, were more, straightforward, like solving a disease control issue, program implementation issue, or just, why particular disease control program is not working, or what is the epidemiological determinants of that. Uh, and uh, and also, okay, this is an old slide. I changed that. Public health training was also focused on epidemiology. Like most training was happening in medical schools with the community medicine department, with later on evolution of more and more MPH programs since 2000 or 2000 up to 2005, and more lately, I think there are almost hundreds of institutes offering masters in public health. So, but I also, when I dig into history, and I also feel that H, the different component of HPSR was happening in India. It was not like it was completely absent. So it was happening since long time, but it was a very piecemeal practice. The social science researcher doing their own bit, the community medicine people doing their own bit, the other public health professionals doing different kind of research, but there was very little, and that was, and we had like operational research, implementation research, health services research coming into discussion quite often. Even in 2009, 8, when I was kind of going through those trainings and other things. But then I think the HPSR discussion about HPSR, the terminology of, popularization of terminology of HPSR probably is a recent phenomenon. And I may be wrong on some of this assumption, because many people sitting in the room, especially Dr. Deva and Dr. Prasant and many other, I cannot see everyone, but they know much more about this evolution and things. So they may add on to it during their discussion with the fellows later on. And multiple fragmented disciplinary practices were doing, like economists. When I worked with Center for Health Policy at Asian Development Research Institute in Patna, one thing I realized that economists were doing lots of health research, and there were hardly any interaction between economists and public health researcher doing joint collaborative effort. And HPSR probably is in a venue where they are coming together. Like we had, we know that Melbourne School is one of the collaborator for India Health Policy at HPSR. So I remember Dr. Ajay Mahal visiting one of our seminars in Adri, and he emphasized that what we need in India is health policy and system research practice. So that was a very kind of insightful at that time, because that was a gathering of economists from all over the world. Can we go to next slide? Lately, and I think one of the reasons HPSR got popularized in recent time was training opportunity. First Keystone, which happened in 2005, and then I'll give lots of credit to India Health Policy and System Research Fellowship Program by the Health System Transformation Platform, because this is a continuous process. More number of fellows are getting exposed to this training, and we are kind of developing this community of HPSR thinker and practitioner and collaborators. And I think lately the training courses embedded within the Masters of Public Health and some of the community medicine department also. I delivered HPSR talks in some community medicine department, once in Varda, recently in Raipur. And then PhD program is also emphasizing on a lot on HPSR thing. And I also believe that with this kind of growing tribe or growing community of HPSR practitioner, there is probably some, maybe just a small fraction of percentage, increased demand of HPSR kind of solution or thinking, or kind of identification of problem by the policy elites. And it is also popped up, kind of, it is also influenced by changing landscape of public health care in India. Like when we were growing as an MBBS student, or like we were even in when I was doing MD in community medicine. So it was very much hard, kind of very kind of closely ingrained in our mind that public health should be publicly driven. But now with this introduction of national health policy in 2017, and then subsequently government deciding to set up this PMJY and by purchasing selective care from private sector, it's not all publicly driven system. We can debate about what is better, what is not, but But the situation is that in addition to existing complexity of public health system, the public health practitioner or HPSR practitioner or researcher now have to deal with all these things. Earlier, probably economists were pushing for that, or public health practitioner with health economics focus were discussing that. Now everyone has to deal with that, because now these two systems are kind of entangled. And also emerging group of practitioners are helping this, as I said, but the challenges remain. Because as Dr. Bontababu tried to highlight, Dr. Rajiv sir highlighted, I think the challenge is that still that the response time in health system, real-time response in health system is very low, very short. There are, I will say, ethical and administrative challenges of conducting health system research, because many of time in in HPSR, what we do deal with that our subject is mostly this administrative, especially in health policy, which I focus a lot on. Health policy research, our subject are mostly these policy elites, or like policy entrepreneurs, or like, policy, one of the policy players. So how to talk to them, how to interview them, and how to, critically analyze their kind of thought processes. As it's a challenge which we constantly do with as a health policy researcher. Can we get to next slide, please? Yeah. So to conclude in the final slide, and that is why I have said that why HPSR is critical for Indian public health researcher, because probably everybody in this room will classify themselves as an Indian public health researcher, because the health system is complex. There is complexity in health system, and I tried to explain earlier. Complexity at all level, macro level, which is more of a policy level, meso level, and micro level, even at the ground level. And when I commonly used to say at SHRC, like the Mitanin, the ASA management in Chhattisgarh was with us till September, and we used to deal with lots of challenges like interpersonal issues of Mitanin program, colleagues and managers. And there were lots of, when there are humans, there has to be soft issues. And when there are soft issues, we have to deal with that. And sometimes researchers have to find solution to those soft problems as well. And more importantly, India is not a one health system. And I think Rajiv sir also said that India as a country is not one country. It's many countries within a country. Similarly, India's health system is not one health system. It's an amalgamation of more than 30 health system, I will say, with 28 states and UT having different system. And there are too little in health system for too many. So this also adds to complexity. And that is why there is need for system thinking and continuous effort to strengthen health system, which will never be kind of final, because as it will be taught to you, health system is kind of, known to be constantly changing and self-organizing and everything. So it will keep changing. We have to keep challenging our own thinking. We have to keep exploring problems with a new dimension. And that is why we need HPSR hat going forward. And that is why I believe that this particular training will also be very important. This will also probably give us some kind of, ability to counter magic bullet narrative, which came into discussion by previous speaker also, that, many times when we work closely with the policymakers or health system actors trying to solve health system problem or trying to help in solving health system problem, they have little time, so they will always look for magic bullets. So systems thinking will gives up some negotiating power to deal with that magic bullet narrative and buying time to introduce, so that we can introduce longer term, more consistent solution. And also that is a leverage which we can use to introduce evidence into policy. And third, why HPSR is critical for Indian public health researcher, because we have to be the change that you want to see in the world, as our father of nation Mahatma Gandhi has said. Because if we will keep thinking straight, if we will keep thinking like in a very causal approach, like causation theory, then probably we'll not be able to provide, then we'll tend to get entangled into magic bullet short-term solutions. So we have to be long-term thinker, we have to be systems thinker, we have to have that health policy systems research lens, which will help us deal with, say, very kind of difficult day-to-day situation in a more systematic manner. And that is a critical skill. Even if some of the fellows may not venture into full-time research to be a researcher later on in life, and with someone who is not into a full-time research always, I have always been in an organization which is more into practice than totally research. I think it is still helpful. And even in SHRC, I'll say one of the way I've dealt with health system stakeholder, and one of the way we get respect within the health system, ecosystem, is by bringing this kind of discussion into onto the table when you sit with multiple different stakeholders with multiple mindset and hat. And I think with this, I'll stop here. Can we go to next slide? And with this, I would like to wish all the best to all the selected India HPSR fellow this time. And I'm sure this is going to be a career changing track of at least some of you, or probably most of you. Thank you. Thank you very much.
Thank you, Dr. Vikas sir, for your smiley, and I hope that throughout the course of this HPSR program, you all have that smile on your face. Now, as we have come to this part of the agenda, we have finally concluded the inaugural session of HPSR Cohort 2024. I would like to take this opportunity and share my deepest gratitude to all who made today possible. First of all, to our esteemed speakers and guests, thank you for sharing your wisdom, your experiences, and for reminding us all of the power of health policy and system research to change lives. Then we thank our incredibly faculty and mentors. Thank you for your unwavering dedication to nurturing emerging leaders in HPSR. We are all sure, we are confident, we are looking forward to your guidance that will light the way of this cohort as they begin their journey. Now to the cohort of 2024. Congratulations to each one of you. You are indeed taking an incredible step. Wish I was a part of you. And last but not the least, let me name each one of you. Thanks to Dr. Bonta Babu, sir, Deva sir, Rajiv sir, Dr. Vikas sir, Dr. Kumanan, Dr. Prashant, Dr. Sumit Kane, Dr. Devki, Dr. Dorothy Lal, Dr. I think we are waiting to hear from them. And HPSR has been collaborating with India and international organizations. So we take this opportunity to thank them also. IPH Bengaluru, George Institute for Global Health, NOSAL Institute for Global Health, ITM Antwerp, Belgium, WHO Alliance, CMC Veller, and Sri Chitra Tirunal Institute of Medical Sciences and Technology. With this, we conclude the launch of Cohort 2024. We are looking forward to an exciting journey with us, HSTP, and sorry, I forgot, the team that made that possible, the team from Health System Transformation Platform, the team of organizers, volunteers, technicians, who really looked and gave attention to every detail so that this 3 days of your journey, of your sessions, of your stay becomes an enjoyable one. Thank you. We are looking forward ahead with us. And now we are breaking for tea, 20 minutes. Be adaptive, have your tea quickly and come back. Thank you.
Well, thank you. Enjoy your tea. Bye-bye.